My name is Ken Mykowski. I am a vice president with our customer sales support group. I'll give a very quick overview of what Surescripts does and how we convey information to our technology vendors. And then I'll be turning the rest of the presentation over to Ruben Felke. Ruben is with Healthcare Systems, one of our longtime technology vendors who provides medication reconciliation products and services to the hospital industry. If you're interested in more of their product, they're over in 3310, if I'm not mistaken, down the line. Let's get into the presentation. I don't think I have to tell all of you some of the statistics about the issues that exist from not understanding what medications a patient is on. The amount of adverse drug reactions, the deaths that occur, medication errors that occur, readmissions that occur because people don't understand the medications a patient is taking is very high. The service we're talking about here basically is going to help with that transition of care between the patient's home and the acute care setting. Probably the most difficult transition for clinicians to be able to document. We've been doing this for a while. Surescripts has been in business for 10 plus years. We've delivered billions of transactions and hundreds of millions of medication histories to electronic medical records for e-prescribing. And this service is probably deployed in just about 1,000 hospitals in the United States through various technology vendors. So we have a fair amount of experience. It's scalable. There's a lot of information there. What we're basically doing is, at the point of a patient's admission, delivering in real time, literally seconds, a medication history from either a PBM database, claims database, or from a pharmacy fill database, and putting that together, sending it to your chosen technology vendor, so then now you have a product to start the medication reconciliation process. So there's a fair amount of data there, and I'll get a little bit more into that as well. Let me show you how this works from a technical point of view. When the patient is admitted to the hospital, what we require from our technology vendors is an ADT transaction. And what we're basically looking for in that ADT transaction is 5 basic pieces of demographic information: first name, last name, date of birth, zip code, and gender. That transaction is then forwarded to Surescripts. We open it up, and we look at that demographic information, and we have 2 master person indices. One for the PBM data, and we've got about 250 million covered lives, probably about 220 plus million unique individuals. And we have a clinical data repository of pharmacy fill data that gets refreshed nightly from the retail pharmacy industry that has about 2 billion prescriptions in it, about half the prescriptions filled in the United States. If we find the patient in the PBM data, master person index, we send it to the PBM. They query their claims databases, send it back to us. We query the pharmacy database if the patient exists there. We put them together into an HL7 RDS transaction, a discrete data transaction, send it back to our technology partner, who now creates the product that you want for medication reconciliation in your hospital setting. Literally, this happens, you could say 3 to 5, on our side it's about a 2.5 second transaction. You know, with the latencies that occur and some of the things they have to do, this is probably a 3 to 5 second transaction. So it happens in real time. And it can get, the key thing is, it can get into the patient workflow. I can't tell you how important that part of this whole process is. Just getting data to a hospital is one thing, but getting data into a hospital that it gets into the workflow of the clinician who's taking care of the patient at the right time, at the right place, is a totally different thing. And so the key here is working with a partner who's going to get it into the patient workflow. So what kind of things do you get? Again, this is very similar to the type of information that you would get in an NCPDP medication history transaction. You're getting the name of the drug, the NDC of the drug, you're getting the fill dates, you're getting the prescriber, you're getting the pharmacy that fills it, and from the pharmacy data you actually get the SIG data. That SIG data is the take 1 tablet twice a day type information. The key to this data is it's longitudinal in nature. We go back a year. So basically, this data is going to say, Ken Mykowski got his antihypertensive, his 30 days of antihypertensive filled on June 1st, July 1st, August 1st, September 1st, or November 1st, October 1st. Or it might say you got it filled on June 1st, July 24th, September 23rd, and November 5th. And if I'm coming in with high blood pressure and your clinicians are trying to decide, do I add another drug? Do I increase the dose? Do I put them on a stronger drug? Or how about if I just get them to take what I prescribed to start with, to help answer this question? So this is longitudinal in nature. Technology, different functionality exists within our different technology vendors as to what can be done with the data. But this is a precise, accurate, longitudinal view of how a patient purchases medications at a hospital or uses their benefit to do this. I refer to this as that little electronic brown bag of drugs you wish the patient brought with you. Now, what I want to say is, just like that brown bag they might walk into the hospital with, somebody still has to do something for it. This isn't the be-all, end-all. It's the start of a process, okay? Start of a saga in the hands of a good clinician, from my point of view. You still got to go in. Are you the right patient? Are you taking these pills? You open that little brown bag and you look at the pill bottle and there's 3 different pills in it, and you got your husband's pills here and your wife's pills there, and somebody still has to go through and talk to that patient to get to the real source of truth. No different with digital data, but this gives you a really good head start. And some of the benefits, I think, are really key. It improves medication reconciliation. It has some quality aspects. You've seen one medication reconciliation process, you've probably seen one. Nurses are doing it, physicians are doing it, pharm techs are doing it, pharmacists are doing it. This is a digital feed of the NDC code of what was actually dispensed by the pharmacy, so that when your nurse or pharm tech is sitting there and trying to decide, did that patient say Prozac or Prilosec, or trying to put that into some generic name, or trying to roll up multiple generics because of what was dispensed over different periods of time, this will coalesce all that information and get a clean list of drugs the patient's been taking. So quite a few features and benefits to the process. A couple things. We had a group do a quick study in an emergency room up in north of Pittsburgh. A couple real key things. An instantaneous medication history versus a 20-minute interview of a patient brought back about 30% more drugs than the 20-minute interview did. For the additional, in order to get to the same level that they got from the digital feed, they would have to spend another 20 minutes at least over and above the initial review. And probably most importantly, no, that's okay. No, probably most importantly is the types of medications patients forget. And they included controlled narcotics, nonsteroidals, antibiotics, central nervous system drugs, and cardiovascular drugs as the top drugs that patients would forget to tell the person who is doing medication reconciliation. As a pharmacist, I know these are probably your top drugs for drug interactions, especially the central nervous system drugs. And a lot of the controlled narcotics, well, they're episodic. Well, I'm not taking that because I don't hurt now, but when I do hurt, I take Vicodin, or I was on Vicodin for 2 weeks, a couple weeks ago because I fell and bruised my elbow or something. So there's a fair amount of information and data that are here. If we look at the cost of collection in a hospital with about 260 beds, we think we can save about $1,250 per bed per year. And in the cost of inaccuracy, and this is basically the cost of adverse drug reactions, we think we can save an additional $878 per bed. There's some methodology here. I don't want to get into all that today because it gets a little messy with some of the math, but that's something we certainly can get more involved in if you're interested. So at the end of the day, we have a real-time digital feed from multiple data sources. I think we probably have connections to about 50, 60 different data sources. We maintain those connections. This is coming through an ISO 27001 certified network, so it's safe, secure. We've been doing this for 10 years, and we have a lot of experience doing this. And what I want to do now is turn this over to Ruben, because I think what is really key is, all right, I'm giving you a data feed. What does it look like? And what are some real patient stories that exist out there as to what the real advantage and the features and functionality of this data is. I'll see you at the end of the presentation to give away that watch, and Ruben, I'm going to turn it over to you.
Thank you, Ken. So as Ken said, I'm with Healthcare Systems, and we were one of Surescripts' early adopters of the medication history service, actually back from when it was Legacy RX Hub, started receiving medication history. Um, so we're going to talk a little bit about HCS's background. As a company, we've been around for just over 30 years. We do workflow solutions. We've got lots of different technology solutions. We're going to focus on the medication history component and the medication reconciliation. That 5 years is a little bit of a misnomer. That was with Surescripts when Surescripts and RX Hub merged. We've been a vendor doing this for just about 10 years now, and we've got hundreds of hospitals that are using different products where the medication history is the foundation that helps with their medication management process. So again, we've got a bunch of different solutions. 3310's like 50 feet that way. If you'd like to hear more about some of the other things we have, we're going to focus on the MedRec side here. And how that plays into some of the other products as we go through. The whole medication management process is garbage in, garbage out. One of the hardest things is getting an accurate medication history, and that medication history feeds your whole medication management process. This particular thing was about our barcoding at the bedside application, but one of the key factors in them improving their accuracy was making sure they had an accurate medication history to feed the physician's orders and then do the medication administration. So today what we're going to do from a structure to carry through is talk about that patient coming in, the transitions of care component, both outside the hospital, them coming in at admission, and then transferring between levels of care, which most hospitals are defining as into and out of surgery and into and out of the ICU, and then moving through to discharge and how that information gets communicated through at discharge. To fit your medication process. And as Ken said earlier, when we started this with medication history, we sort of had a mindset that it was so valuable that if we just put it out there, people would use it, and they would, they would love it and they would do it. And what we found is that in the busyness of an emergency room or some of those other type environments, we had a little bit of resistance. Isn't exactly the right word, but it's close. To those folks who said, right now, if I were to sit down and say, what meds are you taking? And you told me you were taking 2 medications, and I wrote those 2 meds down, I'm done. But if I get my medication history query and I've got 8 meds on it, and I may go through it and find out that you're not taking 2 of those medications anymore and you're taking 6 medications now, I'm a whole lot more accurate, but it took me a more detailed interaction with my patient to get to that point. And so we really, in order to really drive the value of this, had to do a consultative implementation process to really make it part of the workflow and work with those organizations that are essentially self-selecting as being quality organizations that are interested in focusing on an accurate medication history. So, as you probably all know, the biggest challenge is getting that accurate list where patients make poor historians, and if you're dependent upon their history and what they're telling you, you're going to get that, well, I take a blood pressure med and it's a something Pril, to try and remember what their meds are, and certainly doses. The average Medicare patient seeing just over 6 doctors over the course of a year, getting 18 different prescriptions, near impossible for them to keep up with what medications they're taking as they go through that process. Okay, so medication history as we're transitioning into admission. Again, if you don't fit it into the process, people aren't going to use it. And so we do trigger, as Ken said, it's a requirement from a HIPAA perspective. I can't just let you go type Bob Smith in and your neighbor's address and look him up and say, gee, what meds is he taking? I really need to have something that says this patient, there is an actual patient-provider relationship, and that's what using that ADT feed accomplishes for us. So when the patient gets registered in your hospital, we get that transaction. We use that to trigger the query taking place. The other thing that accomplishes is it allows us to push the medication history into your workflow. So instead of your clinicians having to go log into another application, look up the patient somewhere else, say they want to do a query, this process makes that all happen as part of something your clerk, your registration staff was already doing. So the query comes back. We do a bunch of analysis on it. Surescripts is going to send back all that raw fill data that Ken talked about. What we do is analyze it and compress it down. So you're going to see a single line item per medication that the patient's taking. You're going to see when it was originally filled, when it was most recently filled. We can show that graphically for you on a timeline so that you can see gaps in compliance for when if your patients were taking the meds they were supposed to, they would, the way they were supposed to, they would have not had any medication remaining. And we're going to do checks for drug and duplicate therapy, those type of things, and we're going to alert the appropriate clinicians to that. We're going to push that into your workflow, either into your existing EHR, or we have our own application that we can use to do that. Again, the point being, it is not replacing that clinician interaction with your patient, just providing a better starting point so that they can see what meds the patient's taking. Okay, so we're going to move through just a couple case studies to talk about this. As Ken said, on average, you see about 30% improved medication history. What this particular case study was at a large teaching facility in Houston. They had pharmacists that were conducting medication history interviews for every patient that came through the ED and got admitted. And so that, all the studies say the pharmacists were best at collecting that information. This particular study, we took 500 patients. We did they did their initial interview, and then we did a medication history interview, or a medication history query from Surescripts, and they re-interviewed their patients. And exactly those classes of medications that Ken's were talking about, they found 2.4 additional medications per patient as they went through that interview process. And this was with pharmacists doing it. We've seen much higher in some other cases. Okay, so this particular case is an example where we're using our software to augment the medication ordering process. So what this study was is this hospital had physicians that were ordering medications, of course, off of that medication history list, but oftentimes that whole process gets messy. The doctor may admit the patient, send them over with admission orders in hand and say, these are the meds I want the patient to start on when they get to the hospital. Then the nurse conducts the medication history interview and finds out that the patient's taking anticonvulsants, cardiovascular, other meds that the primary care doctor that admitted the patient wasn't aware of. This hospital used our software to implement a process where the pharmacist got an alert sent to them on high-risk drugs that the doctor had not started on admission in order to identify those. It made it a very efficient way for them to identify those gaps in care and significantly reduce the number of clinical omissions they had as they went through the process. This is talking about the whole medication reconciliation process and how it fits together at discharge. We used 5 different size hospitals and doing an analysis. This was a before study of a hospital that was utilizing paper for their medication history process, and we literally stood there with stopwatches and watched their nurses go through that process of how it all fit. The vast majority of the time savings that you see, and that's pretty significant, came at discharge because a lot of hospitals have a really messy discharge process where the doctor may do their discharge orders on paper and they're doing a weird comparison between home meds and inpatient meds, and it's 2 different lists or it's on the same list but separated out. Then they're trying to pick which meds they want the patient to go home on, but of course they're doing it in doctor handwriting, and then the nurses are rewriting the medications in patient-friendly terminology and something you can read to do that. You can get a very lengthy process, and of course is very error-prone. By making that full process electronic, tying an accurate home medication history in with the inpatient medications so that it's easy to see those, you achieve huge time savings, but also you're much more accurate even as you're increasing your efficiency. And then to the point of accuracy, this particular study, the hospital that brought us in because they realized they were failing their congestive heart failure core measure almost solely because their medication reconciliation process was bad. You're required, of course, to make sure that the medications the doctor ordered are the same as the medications the patient has in their list when they're sent home, and those are the same as are in the discharge summary that the patient receives, or that goes into the chart. In this particular case, we automated that full process for them as part of the time savings that we did, and saved a bunch of time, but also completely eliminated any errors in their congestive heart failure as a result of the transcription issues of doctors trying to dictate from memory about which medications they're going home on. And so the medication history portion really does tie all the way through from admission through those transfers of level of care and at discharge. Having that accurate starting point is key, both from an accuracy and an efficiency perspective as we go through that process.
I thought there was a point you made that is really key, is that this medication history that you might access during the point of admission has a whole lot of value at the point of discharge. If you're, now the patients come in, you're on your hospital formulary, you've written different drugs, maybe the same therapeutic category, and as you're discharging that patient, if you think about that medication history you got at admission, those are the drugs that are sitting in the patient's house. And if you're going to be writing a prescription for a ACE inhibitor, that's different than the one that they have in their house, and now you're at risk for readmission, it would really be nice to know that you're trying to get this patient on 2 ACE inhibitors when you only want them on 1. So I think the value of the payload and the value of the service you get not only is something that is benefited at the point of admission, but really important at the point of discharge. So first thing I want to do is collect cards from you, because that's what we're going to be doing the drawing from. Let's do that. But then ask you if you have any questions or anything for either myself or Ruben about the data we provide, the service he provides, or any other information we might be able to share with you.
I was a bit confused about your connection again.
So Surescripts is purely an infrastructure company. We don't have an end user interface. We're connected to an e-prescribing, 650 applications who have e-prescribing functionality. We're also connected to a number of technology vendors who have medication reconciliation products and services that they sell into the hospital world. So they're one of our technology vendors. So we also have others, and we're connected to Siemens and Cerner and Epic and a few others. These guys have been a long-term partner of ours, and they always have great case studies, and I always like to have them participate with us. But we are an infrastructure company that just feeds the data payload. These guys take it, as he says, compresses it, deduplicates it, massages it, does drug utilization review on it, maybe a medication possession ratio, puts it into a chart so you can see what the patient's medication is over a period of time. And they take data and hopefully create wisdom.
So does that mean that you could do the same thing to your physician EHRs?
We provide medication history to all of our e-prescribing physicians as part of the process today.
So
that's part of their e-prescribing application. Our whole point in e-prescribing is to provide decision support information, both medical and economic, so that the physician is writing the most medically and economically appropriate prescription at the point of care. Okay, so we provide that as well. Yes, sir.
Do you need any type of patient consent to pull this data?
So the answer is yes. Contractually, with all of our technology vendors, what we have is the ability, is consent to start with. In the NCPDP transaction, there's actually a consent flag. What we really require is that they follow all applicable local, state, and federal laws that relates to security and privacy. And frankly, the consent mechanisms in Rhode Island and the consent mechanisms in Missouri are different. And if you're going to do business in Rhode Island and in Missouri, he as a technology vendor doing business in those states needs to understand that with his end user, and then those consent mechanisms have to apply in order for this payload to be queried.
Part of the benefit of what Surescripts is able to do, and we have a number of customers that are health information exchanges, part of the benefit that we're doing is consent mechanism. Yes, absolutely, you have to have a patient consent. And the way that usually works is, and part of why we use the ADT transaction is because you're not going to register a patient in your hospital until that patient has signed a consent to treat. And in most states, that consent to treat establishes the provider-patient relationship, which enables, of course, the P in HIPAA. Everybody talks about privacy, but portability. Once you've got that provider-patient relationship for purposes of treatment, in almost every circumstance, you're authorized without any additional consent from the patient to do that. As Ken said, there are some unique circumstances, and certain states have different rules about mental health patients and those sort of meds. But in most cases, that provider-patient relationship is the consent that you need. There's no additional step you have to add to your workflow in order to authorize the use of this data. Just to add to that consent to do a particular use case, one of the very first hospitals I went into 7 or 8 years ago when we first started doing this service, we had a guy come in that in the ED, first night that we just installed the software, was post-dictal. He was in Pennsylvania, could barely even remember his name, much less the meds he was taking. Of course, just had a seizure. They pulled his wallet out. They were able to enter his information and register him as himself in the ED system. We got the query and response back in 30 seconds. They were able to identify that he was hypoglycemic and why he had gone into the seizure. They had his exact dosages of his insulin medication. They knew what his anesthesia medications were, and were able to immediately start care knowing a whole lot more information than they would otherwise have known. And it kind of plays into that consent question of, hey, I'm here for care, and they know they could access that information.
Yeah, I think the other thing, you bring up a good point. If you look at a medication history list, and again, I'm a pharmacist, and there's only one professional group out there who likes looking at long lists of medications, and it's pharmacists. But if you think about what else it offers you in a case like you just said, it also starts being a proxy probabilist. The patient comes in post-ictal after a seizure, and you have no idea that they're diabetic. But all of a sudden, their medication history list comes back, and they're on insulin or on an antidiabetic. They're on a congestive heart failure drug. All of a sudden, you start getting an idea of what the patient's problem list is, as well as what their medication history is. So from a clinician's point of view, I think the value there is relatively large.